Hello everyone. Today we'll talk about the classification and the treatment of MDS. As we know, there are two classification systems for MDS. That's FAB and WHO classification of MDS. In 1982, the FAB group proposed a specific MDS classification that included 5 entities: refractory anemia, RA, refractory anemia with ring sideroblast, RARS, refractory anemia with excess blast, RAEB, and refractory anemia with excess blast in transformation, REBT, and chronic myelomonocytic leukemia, CMML. RA is characterized by less than 5% myeloblast in the bone marrow, and the pathology abnormalities primarily seen in red cell precursors. RARS is characterized by less than 5% myeloblast in the bone marrow and the presence of 15 or greater red cell precursors in the marrow, being abnormal iron stuffed called ring sideroblasts. REB is characterized by 5 to 20% myeloblast in the marrow. REBT is characterized by 21 to 30% myeloblast in the marrow. CMML is characterized by less than 20% myeloblast in the bone marrow and greater than 1,000 monocytes circulating in the peripheral blood. A classification of MDS was defined by the WHO in 2008 and finally revised in 2016. It includes 6 major subtypes distinguished by the type and number of dysplastic lineages, the proportion of myeloblast, and in one subtype, the presence of a specific chromosome abnormality, del5q. These subtypes include refractory anemia with unilineage dysplasia, RCUD, refractory anemia with ring sideroblast, RARS, refractory cytopenia with multilineage dysplasia, RCMD, refractory anemia with excess blast 1, refractory anemia with excess blast 2, myelodysplastic syndrome unclassified, MDSU, and MDS with isolated del5q. RCUD is defined as a dysplasia in no less than 10% of cells from a single myeloid lineage. There is less than 5% myeloblast and no all rows, and less than 15% of erythroid precursors are ring sideroblast. Most often is refractory anemia, but can be refractory neutropenia or refractory thrombocytopenia. RARS is characterized by isolated erythroid dysplasia. There is less than 5% myeloblast, less than 1% blood blast, and no less than 15% ring sideroblast. MDS with del5q is defined as with 5q31 deletions as a sole chromosome abnormality. There is normal to increased megakaryocytes with hypolobulated nuclei in the marrow and normal to increased platelet count in blood. There are also less than 5% myeloblast, less than 1% blood blast, and no all rows. RCMD is defined as dysplasia in no less than 10% of cells from 2 or more myeloid lineages, and there are less than 5% myeloblast, less than 1% blood blast, and no all rows. Blood monocyte count is less than 1,000. REB1 is defined as 5 to 9% myeloblast, less than 5% blast, and no all rows. REB2 is defined as 10 to 19% blast, less than 5 to 19% blast, or all rows. blood monocyte count is less than 1,000. For MDSU, there is minimal dysplasia in the presence of clonal cytogenetic lesions considered presumptive evidence of MDS. There is less than 5% marroblast, less than 1% blood blast, and no aureoles. In 2016, WHO renamed the entities of MDS. RCUD is changed into MDS-SLD. RARS is changed into MDS-RS. RCMD is changed into MDS-MLD. If there is a syndroblast in MDS-MLD, it's called MDS-RS-MLD. REB1 is changed into MDS-EB1. REB2 is changed into MDS-EB2. Their 5Q and MDSU remain unchanged. For the treatment of MDS, we have supportive care, chemotherapy, DNA methyltransferase inhibitors, immunomodulators, stem cell transplantation, etc. All patients, regardless of risk score, deserve best supportive care. Supportive care consists of improving quality of life by treating of cytopenias and their complications. For example, red blood cells or platelet transfusion should be administered for anemia or thrombocytopenia. Febrile events are common in higher risk MDS. Appropriate broad-spectrum antibiotics should be used. For low-risk MDS, colony-stimulating factors such as EPO, GCSF, or TPO can be considered. The magnitude of risk from iron overload in patients receiving frequent RBC transfusions compared to the deaths intrinsic to the disease. Several guidelines make recommendations about iron monitoring and chelation. Since the 1980s, low-dose cytarabine has been used in MDS. Although this approach leads to remission in 10 to 20% patients with MDS, the median duration of remission is less than 1 year. This treatment approach is used less often since other FDA-approved agents for MDS, especially as azacitidine treatment is associated with super overall survival. Other therapies for high-risk MDS patients include DNA methyltransferase inhibitors and stem cell transplantation. There are 2 DNA methyltransferase inhibitors now have been approved in MDS, including azacitidine and decitabine. As we just said, azacitidine is the first agent shown in a randomized fashion to extend survival in MDS. Decitabine is also FDA approved for all MDS categories. Compared to azacitidine, it may work faster. Therapy with DNA methyltransferase inhibitors in patients who are not suitable candidates for HSCT usually continues for as long as it seems like the patient is deriving benefit, and as long as the drug is well tolerated. Allogenic hematopoietic stem cell transplantation remains the only treatment that can cure patients with the disease, yet the morbidity and mortality of transplantation for MDS remains high. That's all for today. Thank you for your attention.